السلام عليكم ورحمة الله طلبتنا الأعزاء. في سلسلة محاضرات Clinical Nutrition. Today we will talk about malnutrition. Malnutrition can be defined as a state of nutrition in which a deficiency or excess of energy, protein and other nutrient causes measurable adverse effect on body composition, body function and the clinical outcome. Malnutrition تشمل both undernutrition and overnutrition. And both of these conditions lead to change in body composition, body function, and the clinical outcomes. So what are the causes of undernutrition? Undernutrition is mainly caused either by decreased energy intake or by increased energy expenditure. Decreased energy intake include famine, المجاعة, persistent regurgitation or vomiting, anorexia, malabsorption, and maldigestion. While an increased energy expenditure because of an increase in basal metabolic rate like thyrotoxicosis, trauma, fever, cancer, or cachexia. Excessive physical activity, marathon runners, energy loss, glycosuria and diabetes, or impaired energy storage as a condition like Addison disease or pheochromocytoma. Clinical features of undernutrition include weight loss, thirst, craving for food, weakness and feeling of cold, nocturia, amenorrhea or impotence, lax pale dry skin with loss of turgor and occasionally pigmented patches, cold and cyanosed extremity, pressure sores, hair thinning or loss, muscle wasting, okay, loss of subcutaneous fat, hypothermia, edema, distended abdomen, decreased tendon jerks, apathy, loss of initiative, depression, introversion, aggression, and susceptibility to infection. These are all clinical features of undernutrition or weight loss. How to screen for malnutrition? It is important for every patient entered into the hospital to be screened for malnutrition so that you can take measures to avoid um, further complications. This is a must which malnutrition universal screening tool commonly used and includes three main items: the BMI score, the weight loss score, and acute disease effect score. So if the BMI is more than 20, you give 0, while if the BMI less than 18.5, you give 2 scores. When weight loss, if there is less than 5% weight loss over 3 to 6 months, you give 0, while if there is more than 10% weight loss, uh, then you give 2 scores, 2 marks. If the patient is expected to not to eat for more than 5 days, then you give a score of 2. You طبعا تجمع هذني السكورات وتعطيك رقم. الرقم إذا كان 0 معناها low risk for malnutrition. If the score is 1, there is medium risk. If there is more than 2, then there is high risk. Here, if there is medium risk, the patient need to be investigated and to be followed up over the days while he stayed in the hospital. While if there is more than 2, then you have to intervene to prevent further complications and further deterioration in the nutritional status of the patient. So what are the consequences of malnutrition? Why we need to treat malnutrition? Because malnutrition impaired immune function and the patient become more susceptible to infection, delay wound healing, muscle wasting and weakness include respiratory muscles, cardiac muscle, and mobility, the skeletal muscles, alter the gastrointestinal function, lead to malabsorption, and this vicious cycle, malabsorption, further malabsorption, and then further deterioration in GI function. General sense of weakness and illness. So to diagnose protein energy malnutrition, we focus, as we said, on the BMI the history of weight loss, and if there is any acute disease. Investigation. To investigate malnutrition, we send, for example, plasma-free fatty acid increased, glucose decreased, albumin is either increased or decreased or remain the same. Hormones, insulin decreased, glucagon, cortisol, and reverse T3 increased. Mild anemia, leukopenia, and thrombocytopenia. ECG show sinus bradycardia and low voltage. Management of malnutrition in 3 stages. First, initial evaluation. Second, resuscitate and stabilize, and then refeed. So the initial evaluation, careful clinical examination, send for investigation, check the fluid, plasma glucose, electrolyte, acid-base abnormality, search for infection, like sending for urine analysis, CBC, blood culture, chest radiograph should be considered even in the absence of physical findings of infection. Initial supportive care, judicious resuscitation with the fluid and electrolyte is very important before feeding of the patient. You have to correct any electrolyte abnormality. You have to supplement vitamins, okay, and warm the patient uh, because they are more liable for hypothermia. And then refeeding. So the goals of refeeding is to prevent further deterioration and correct abnormalities, to restore the normal organ function and metabolism, and to replete deficient nutrient stores. Oral or enteral tube feeding are preferred to parenteral nutrition because of fewer serious complications and enhanced gastrointestinal tract recovery. Feeding should be given in small amount at frequent intervals. Small amount of oral feeding should be given frequently, every 1 to 4 hours. Enteral feeding by continuous drip or by parenteral nutrition by continuous infusion. So small doses of food should be given more frequently than large doses in less frequent intervals. Sodium intake should be limited, while you should replete phosphorus, potassium, and magnesium. Daily monitoring of body weight, fluid intake, urine output, plasma glucose, and electrolyte is very important. So during refeeding, there might be a complications. What is the complication is that there might be electrolyte and mineral deficiency during refeeding process, and this will lead to many complications we will talk about later. So refeeding, what will happen is that when you uh, food enter inside the body, then the anabolic process will start again, and this will use glucose, vitamins, and minerals. So it will lead to deficiency in these um, component in the blood and may cause complication, hypokalemia, hypomagnesemia, hypophosphatemia, thiamine deficiency, salt and water retention, and edema. As you can see here, the patient will have delirium, epilepsy, ataxia, Wernicke encephalopathy, arrhythmia, hypotension, and cardiac failure, anemia, uremia, diarrhea, and ileus, peripheral edema. So the complication, to rephrase again, fluid overload, mineral depletion, glucose intolerance, cardiac arrhythmia, and gastrointestinal dysfunction during the refeeding process. If you give large amount of food in, in more frequent, in short interval, or you replete or refeed the patient without correcting for electrolyte abnormality. The second part of this lecture about malnutrition is to talk about nutritional support. So we have mainly 2 types of nutritional support, either enteral or parenteral. The enteral nutrition, it is a liquid supplement nutrition taken by mouth or is given by a feeding tube, nasal or oral feeding tube, either nasogastric, nasoduodenal, or nasojejunal. While feeding a tube that, if there is, for example, closure here, complete obstruction in the esophagus, you can do percutaneous gastrostomy or percutaneous jejunostomy. So يعني إذا أكو انسداد هنا راح نقدر نفتح عن طريق الجلد ونطب داخل الاستومك أو داخل الججنة، ويقدر المريض طبعا راح يشوفكم الصورة بعدين أنه يتغذى من خلالها. النوع الآخر هو البارنترال نيوتريشن اللي هو either by central vein or peripheral vein. So many patients with functioning GI tract do not or cannot eat a sufficient amount of nutrient by mouth to restore, repair, or maintain physiological system. The first option for providing adequate nutrition is to deliver it orally. يعني أكو ناس هواية مرضى يعني هو يقدر يأكل لكن كمية الأكل هاي ما راح تنطي الكفاية اللي تغطي هو حاجته في ذاك اليوم، باعتبار أنه هو أصلا مريض ويحتاج إلى كالوريز أكثر. فبهالحالة لازم ننطي للمريض nutritional support. This patient can be given small, frequent, nutrient-dense meals with an oral liquid nutritional supplement. هسه إن شاء الله راح أشوفكم الصور مال nutritional supplement. And then, if oral intake remains suboptimal, despite attempt to increase nutrient intake with a nutritional supplement and diet changes, then enteral feeding can be initiated to meet nutrient and energy requirement. يعني إذا انطيناه nutrient dense meals وبقى هو بعد ما حقق التارجت اللي احنا نريده بالنسبة للكالوريز اللي يحتاجها بذاك اليوم، فنقدر نعوضه الباقي عن طريق البارنترال nutrition. If it is not feasible to use the GI tract for feeding, يعني إذا أكو contraindication for feeding through the GI tract, then we can use parenteral nutrition. Using enteral nutrition help preserve the intestinal mucosal barrier function and integrity. يعني هي الأولوية إنه الانترال مو البارنترال، لأن الانترال راح يغذي الميوكوزا مال GIT، يمنع إنه تصير complications بالمستقبل. ومن ضمن الكومبليكيشن إنه البارير مال الميوكوزا راح يصير بريك داون، وبهالحالة البكتيريا راح تدخل البلد وتسوي سبسز. فطبعا الأولوية هو للانترال فيدينج، لأن طبعا الميوكوزال سيلز تتغذى عادة من الفود اللي هو inside the intestine rather than from the circulating blood. زين. In critically ill patient, feeding the GI tract has been shown to attenuate the catabolic response and preserve immunological function. يعني حتى الدراسات وجدت إنه الانترال هو أفضل من البارنترال feeding. فهذا الالجوريثم يشرح لنا بالضبط إذا أجانا مريض with malnutrition شنو نسوي له. فنشوف إذا عنده هو يعني السكرينينج أثبت إنه هو high risk for malnutrition و nutritional support is indicated. فنشوف إذا كان أول شيء oral nutrition is possible and safe، يقدر يأكل هو المريض، فبالحالة نقدر نسوي له dietary fortification، يعني تغذية عن طريق الماوث، highly dense nutrient food اللي هي specialized formula that can be given to this patient to replenish their nutritional status. يعني أكو نوع من السبلمنت جاهزة تقدر تعطيها للمريض، تحتوي على فيتامينات ومينرالز وبروتين كفاية، فتعوض النقص الحاصل عن طريق الأورال نيوتريشن. إذا لا ما يقدر، يعني الأورال نيوتريشن مو كافي، فنشوف الجي اي تي. إذا كانت الجي اي تي ماكو كونترا انديكيشن فور انترال فيدينج، فالبريفرنس هو فور انترال فيدينج. إذا لا أكو كونترا انديكيشن for enteral feeding, then we give him parenteral. بعدين الانترال فيدنج هم يتقسم الى شورت تيرم ولونج تيرم. اذا شورت تيرم بايز نيزو انترال تيوب، يعني صوندة طبعا عن طريق النوز توصل للاستومك ومن خلالها نقدر ندفع الاكل للمريض. لا اذا كانت هاي العمليه راح تطول اشهر، اكثر من شهر، فبالحاله نسوي لهم جاستروستومي او جيجينوستومي. بالبارنترال فيدنج هم نفس الشيء، اذا كان الشورت تيرم الافضل نعطي بارفرال بارنترال نيوتريشن، اذا كان لونج تيرم الافضل نعطي سنترال فينس بارنترال نيوتريشن. هاي مثل تلاحظون نيزو انترال feeding through the nose, and then this tube you can give food by it، يعني liquid formula. وهذا طبعا المريض اللي احتمال عنده انسداد بالاسوفاجس فمسوي له permanent يسموها percutaneous gastrostomy، ومن خلاله يقدر يدفع الفود اللي هو يحتاجه ويقدر يعيش حياته طبيعية. هاي طبعا انواع الانترال فورميلا مثل ما تشوفون، اكو مثل ما قلنا اورال نيوتريشنال سبلمنت، يعني هايلي دنس فود يقدر ياخذها المريض، واكو انواع فورميلا اللي هي مثل هذني اللي تنطي عن طريق التيوب، يعني تندفع عن طريق التيوب. Potential benefit of enteral nutrition. A physiological benefit include maintain the GIT mucosal integrity, preserve gut barrier function, promote digestive and absorptive capability of the GI tract, augment cellular antioxidant system, decrease incidence of hyperglycemia when compared with parenteral nutrition, and also certain nutrients are not available in parenteral nutrition form like fibers. يعني الفايبر موجود فقط بالانترال not in the parenteral. وطبعا اذا انت تعطي parenteral ما راح تقدر تتحكم بالكميه مال النيوتريانت، فاحتمال يصير المريض عنده هايبرغلايسيميا، بينما بالانترال احتماليه الهايبرغلايسيميا less. Immunological benefit of enteral nutrition decrease bacterial translocation، مثل ما قلنا يصير بريك داون gastrointestinal wall، فالبكتيريا تطب من خلاله واحتمال يسوي sepsis. Support the gut associated lymphoid tissue and mucosa associated lymphoid tissue. Lower risk of infection and improve wound healing. Cost benefit. Shorter length of hospital stay، يعني المريض اللي على enteral nutrition يبقى فترات أقصر من المريض اللي على parenteral nutrition، وهو طبعا الانترال less expensive than parenteral and more simplified procedure and equipment. يعني ما يحتاج إلى جراح حتى يجي يسوي له central venous access، ما يحتاج إلى كانولا خاصة معينة، يعني الأورال feeding is okay. وإذا كان عن طريق النيزوغاستريك tube is also easy to be put and to be used. So what are the indication and contraindication for enteral nutrition? The indication if there is severe dysphagia from obstruction or dysfunction of the oropharynx or esophagus, neurological impairment, coma or delirious status, persistent anorexia, increasing nutritional requirement as in burns or trauma. The contraindication inability to gain access to the GI tract، يعني ما نقدر ندخل التيوب. Non-operative mechanical GI obstruction that cannot be bypassed with a feeding tube، يعني اكو obstruction بالGI tract. Intractable vomiting or severe GIT malabsorption، هم معناها المريض ما راح يستفاد من عندها، او اذا كان المريض عنده severe GIT bleeding. Complication of enteral nutrition. Refeeding syndrome مثل ما حكينا، يعني اذا تعطي كمية غذاء كبيرة بوقت قصير بدون ما تسوي الكترولايت replention، راح احتمال المريض يصير عنده refeeding syndrome. aspiration pneumonia، يعني regurgitation of food وراح يطب بعدين بالرئة ويسوي pneumonia. tube displacement or obstruction، nausea and vomiting, diarrhea or constipation. يعني هذا التيوب مرات ما يوصل مكانه أو يطلع من مكانه أو ينسد، فهاي المشاكل عادة اللي تصير بالانترال فيدنج. البارنترال نيوتريشن مثل ما تشوفون هاي أمثلة على البارنترال نيوتريشن، تحتوي على 3 items اللي هي بروتين glucose, and fat, and given by intravenous central or peripheral intravenous route. So the central parenteral nutrition, a large central vein is used to deliver the concentrated solution for nutritional support. Osmolarity of the central vein parenteral formula can be as high as 1700 or 1900 milliosmol per liter. بينما البرipheral parenteral nutrition to use a small peripheral vein, usually in the distal arm or hand, and deliver less concentrated solution for period less than 14 days. Osmolarity هنا نقطة مهمة. الأوزمولاريتي مع peripheral parenteral nutrition is limited to 900 milliosmol per liter or less. لأن أكو ريسك مال ثرومبوفيليبايتس، يعني لازم الأوزمولاريتي معناها راح نقدر ندفع كالوريز كميات أقل، بينما السنترال parenteral nutrition تقدر تعطي calories in a smaller amount of volume of fluid, while in the central peripheral parenteral nutrition تعطي larger amount of fluid volume with less calories. هنا أنا هم نقدر نقول إنه مثلا البريفرال parenteral nutrition ما تفيد المريض اللي عنده heart failure أو renal failure، لأن يحتاج large amount of fluid، وهو المريض maybe fluid overloaded. So يعني الأفضل إنه نعطي central rather than peripheral parenteral nutrition. Indication: massive small bowel resection, intestinal pseudo-obstruction, gastrointestinal atresia, high output fistula or perforated small bowel. يعني high output fistula تعرفون هي connection between two cavities or with the outside, and it will release fluid. So if there is high amount of fluid excreted from this fistula, they call it high output fistula, and this is a contraindication for parenteral nutrition. It is an indication for parenteral rather than enteral feeding. Severe diarrhea or emesis, severe gastrointestinal bleeding. So what are the contraindications for parenteral nutrition? If there is no central venous access, poor patient prognosis، يعني ما نقدر نحصل على central venous access، أو إذا المريض يعني is very sick and with poor prognosis, we should avoid parenteral nutrition if the enteral nutrition is an alternative means of support. يعني إذا ماكو contraindication للenteral nutrition فهذا يعتبر contraindication for parenteral nutrition. الcomplication عادة مال parenteral nutrition either catheter related complication, gastrointestinal complication or metabolic complications. الكاثيتر يعني air embolism, catheter embolization, phlebitis, pneumothorax and sepsis. Pneumothorax عادة during the procedure of gaining access through the central vein may lead to puncturing the pleura and the lung and lead to pneumothorax. GI complication, fatty liver, GI atrophy, metabolic complication, acid-base imbalance, glucose intolerance, metabolic bone disease and mineral abnormality, overfeeding or refeeding syndrome. Thank you very much, and I hope you enjoy listening to the lecture, and to see you in the next lectures. Thank you very much.